hematology and oncology in children. So sickle cell anemia. Sickle cell anemia has a high incidence in African Americans. It's caused by the inheritance of a gene for a structurally abnormal portion of the hemoglobin chain. So basically what happens is a sickle cell crisis is triggered by insufficient oxygen. So whether it's fever, dehydration, stress, any condition that increases the need for oxygen or alters the transport of oxygen. So that insufficient oxygen causes the cells to assume a sickle shape. The cells then become rigid and clumped together, and they obstruct capillary blood flow. So the clinical manifestations of sickle cell anemia occur as a result of that obstruction, and then occur also as a result of increased RBC destruction. So screening for sickle cell anemia is done through something known as SickleDex. So SickleDex uses blood. It can be from a finger stick. It usually results in 3 minutes. If it's positive, then hemoglobin electrophoresis is completed to determine those who have just a sickle cell trait versus those who have the actual disease. Treatment for a sickle cell crisis is always going to include hydration, oxygen, pain management, and rest. So without adequate hydration, the pain will not be controlled. Also, if you ever see a pain medication called meperidine, 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 this pain medication is avoided because it increases the risk of normeperidine-induced seizures. And also, any patient that comes in with a sickle cell crisis, you want to monitor for signs of complication, which would be anemia, decreased perfusion, and of course shock. And then for patients with sickle cell anemia that experience recurrent splenic sequestration, which we'll get into, a splenectomy may be necessary. So a sickle cell crisis, you have several different types. So a vaso-occlusive crisis is caused by stasis of the blood with clumping of the cells in the microcirculation. So this causes ischemia and infarction. This patient is going to present with fever, painful swelling of the hands, feet, and joints, maybe some abdominal pain. Splenic sequestration is caused by pooling and clumping of the blood in the spleen. So this patient is going to present with profound anemia, hypovolemia, maybe shock. A hyperhemolytic crisis is an accelerated rate of RBC destruction. This patient is going to present with anemia, jaundice, and reticulocytosis. And then a patient in an aplastic crisis is going to present with profound anemia and pallor. This is caused by destruction or decreased production and increased destruction of RBCs, which is often triggered by a viral infection or depletion of folic acid. Okay, so hemophilia. Hemophilia is a group of bleeding disorders that result from a deficiency of specific coagulation proteins. So hemophilia is transmitted as an X-linked recessive disorder. It can also occur as a result of a gene mutation. Carrier females will pass on the defect to males. So you have factor VIII deficiency, which is hemophilia A or your classic hemophilia, and then you have factor IX deficiency, which is known as hemophilia B or Christmas disease. The primary treatment for hemophilia is going to be replacement of the missing clotting factor. So on assessment, a patient with hemophilia is going to have abnormal bleeding. That's often detected after circumcision in a newborn. They're going to have epistaxis, joint bleeding that can cause pain, tenderness, swelling, limited range of motion. They may bruise really easily. Their platelet function is going to be normal, but their clotting factor function is abnormal. So in these patients, you want to monitor for bleeding and maintain bleeding precautions. You want to continually assess their neurological status because they're at an increased risk for intracranial hemorrhage. You also want to educate them to avoid any contact sports, and they need protective devices when learning how to walk. They need to wear protective gear when biking, playing, etc., just because for the increased risk for bleeding. Also, a patient who has this joint bleeding, you're going to treat with immobilization of the joint, elevation, and then ice applications as well. Oftentimes, a medication known as DDAVP, which is a synthetic form of vasopressin, it can increase plasma factor 8, and it may be prescribed to treat mild hemophilia. So we have von Willebrand's disease. This is a hereditary bleeding disorder. It's characterized by a deficiency of a protein called von Willebrand factor. It causes platelets to adhere to damaged epithelium. The most important thing to know about von Willebrand's disease is it's characterized by an increased tendency to bleed from mucous membranes. So this patient is going to have frequent nosebleeds, they're going to have gum bleeding, and then they'll have excessive menstrual bleeding as well. Thalassemia major, it is an autosomal recessive disorder characterized by an abnormality in the synthesis of hemoglobin. It is most common in people of Mediterranean descent. So treatment is supportive. The goal is to maintain normal hemoglobin levels through the administration of blood transfusions. So this patient will present with what is known as frontal bossing, or an unusually prominent forehead. They'll have maxillary prominence, very wide set eyes, and a flattened nose. They may have greenish to yellow skin tone, in addition to hepatosplenomegaly. They will suffer with severe anemia, and then they will have microcytic and hypochromic red blood cells. Iron deficiency anemia. Of course, with iron deficiency anemia, the iron stores are depleted. This results in a decreased supply of iron. So your RBCs are going to be microcytic and hypochromic. The main thing to remember is that liquid iron is often prescribed for treatment. It should always be taken through a straw, and teeth should be brushed after administration to prevent staining. Okay, leukemia. So leukemia is a malignant increase in the number of lymphocytes in the bone marrow. So you have excessive immature white blood cells that depress the bone marrow. This is going to cause anemia from decreased erythrocytes, infection from neutropenia, and then bleeding from decreased platelet production or thrombocytopenia. So with the increase in lymphocytes, the leukocytes are usually at an immature stage when they increase. So acute lymphocytic leukemia is the most frequent type of cancer in children. It's more common in boys than girls. So a patient with leukemia is going to present with fever, fatigue, anorexia. They might have petechiae and easy bruising, bone pain, joint pain. So signs of infection are going to occur as a result of neutropenia. Also, they may present with hepatosplenomegaly or lymphadenopathy. They may have normal, elevated, or low WBC count depending on the majority of the cells in the presence of infection. They will have decreased hemoglobin, hematocrit, and platelet counts. The most common sites of infection are the skin, the respiratory tract, and the GI tract. You want to try to prevent against an infection as much as you can. So a patient with leukemia should receive no live viruses, so no measles, mumps, rubella, or polio vaccines. They may receive the Salk vaccine, which is the inactivated vaccine for poliomyelitis. These patients are going to be very fatigued, so you want to provide small meals that require little chewing and that aren't irritating to the oral mucosa. And then, of course, with any cancers, very similarly, leukemia is diagnosed with a positive bone marrow biopsy, which will result in leukemic blast or immature phase cells. Okay, Hodgkin's disease is a malignancy of the lymph nodes. It's a type of lymphoma. Peak adolescence of Hodgkin's disease is mid-adolescence. It is characterized by the presence of Reed-Steinberg cells on a biopsy. Definitely know that. There's a good prognosis, so of course survival rates depend on the stage of disease. This patient is going to present with painless enlarged lymph nodes. The sentinel node near the left clavicle may be the first one to become enlarged. They may also have abdominal pain. The most common sites of metastasis for Hodgkin's disease is to the spleen, liver, bone marrow, lungs, or mediastinum. So definitely know the difference between nephroblastoma and neuroblastoma. So nephroblastoma, or Wilms tumor, the main thing that's going to differentiate it is unilateral, whereas your neuroblastoma is going to cross the midline. So just keep that in mind. So with the nephroblastoma, it's the most common intra-abdominal and kidney tumor during childhood. Its peak incidence is about 3 years of age. So on assessment, there's going to be a unilateral abdominal mass. They may have urinary retention or hematuria. Interventions are going to be surgery with a partial or total nephrectomy. So very, very important. You want to avoid palpation of the abdomen. So you want to be very cautious when bathing, moving, or handling the child. It is very important to keep the encapsulated tumor intact. Rupture of that tumor can cause cancer cells to spread throughout the abdomen. So avoid palpation of the abdomen. Now, your neuroblastoma is an abdominal mass that crosses the midline. So the prognosis is poor. So the younger the child, the better the survival rate. Again, an abdominal mass that crosses the midline, they're going to have the urinary frequency retention, lymphadenopathy. They may even have periorbital edema or supraorbital ecchymosis. So most tumors develop in the adrenal gland. Other sites can include the head, neck, chest, or pelvis. Presenting signs are usually caused by that tumor pressing against adjacent organs. It usually develops before 10 years of age. They may have bone pain, neurological impairment, or respiratory symptoms depending upon the site of the lesion. Okay, osteosarcoma or osteogenic sarcoma is the most common bone cancer in children. It's often found in the femur. So peak age is between 10 to 25 years of age. Oftentimes, symptoms in the early stages are almost always mistaken for normal growing pains, unfortunately. So this patient is going to present with pain. They may have a palpable mass. They're going to have progressively limited range of motion. They may have fractures at the tumor site, and then they may also have limping and the inability to hold heavy objects. Okay, brain tumors. The most common brain tumor is an intratentorial tumor. You also have a supratentorial tumor. Any brain tumors are diagnosed via MRI. The signs and symptoms of brain tumors are going to depend on the location and size in addition to the age of the child. Okay, so brain tumors, this patient may present with a headache that is worse in the mornings and then improves as the day progresses. They may have vomiting that's unrelated to eating, behavioral changes, facial weakness. Any child with a brain tumor, or if they get a craniotomy performed to remove the brain tumor, you want to monitor for signs of increased intracranial pressure. If they occur, you do need to notify the physician immediately. So signs of increased ICP, you're going to have sluggish or dilated, unequal pupils, colorless drainage from the ears or nose. Remember, it could be CSF. It always needs to be tested. If glucose is present, that is indicative of cerebral spinal fluid. And then vomiting is an early sign for increased intracranial pressure. After a craniotomy, a child is never placed in a supine or Trendelenburg position because both of those positions can increase intracranial pressure. And post-surgery, you want to prevent any increase in ICP as much as possible.